Okay, firstly, I apologize. I'm a little late. I was finishing up my ultrasound tech conference, and that's why I made my way here. So this is the third lecture we're taking on the carotid artery Doppler. We've already done Doppler artifacts, and in my last conference, we just talked about the common carotid artery, and we spoke about the normal waveforms, how to optimize the image, how to know some technical factors, and also to see the abnormalities with focal or diffuse disease of the common carotid. Now I'm going to be talking about the internal carotid, the external carotid, the vertebral arteries, and a few cardiac anomalies that can cause aberrant waveform patterns. All right, do feel free to interrupt me by raising your hand, and I can go over something that we don't understand. Now talking about the internal carotid artery, normal as we know is low resistance waveform with a high diastolic pattern. Most common site of occlusion or stenosis is the ICA origin because plaque extends from the carotid bulb. High resistance pattern in ICA stenosis, as we know, the normal low resistance artery can change into a high resistance pattern if it is approaching a stenosis. And those vascular principles are universal. They apply to every artery, irrespective of site. And if the peak systolic velocity raises, then there is significant stenosis. And we'll come in a minute to what the criteria is. This is just giving you an example that this is a power Doppler image telling you that this could be a plaque, this could be a plaque, and there was 255 peak systolic velocity at the site of stenosis, just indicating that there is high-grade stenosis or focal stenosis at that point. Now coming here, and we always speak about color flow aliasing. So color flow aliasing, nothing, is just a rainbow. It just means that there's turbulence of blood flow. This blood flow, which is no longer laminar, and it's become turbulent, molecules flowing all over the place. And another example I wanted to bring to you to tell you what is spectral broadening. Spectral broadening is when the entire waveform is standing on a pedestal. Like it looks like the waveform should just go up like this normally, but here it looks like it's standing on a pedestal, and this is spectral broadening, and this filling in is called the spectral fill-in. Now we are all familiar with this criteria, but I still wanted to go over this again because this is the principle by which we are, or the yardstick by which we are measuring all velocities and assigning a particular range of stenoses. As we know that normal and less than 50%, their values are pretty much the same. But what is the only difference between a normal and a less than 50% is that the plaque is insignificant or negligible in the normal category, whereas there is some amount of plaque in the less than 50% category, whether it's calcified or not calcified. We've gone through that before. Now coming to the next category, which is 50 to 69%. Why is this categorization? This categorization has happened for two reasons. Number one, that the vascular surgery or the endovascular neuro interventionalists, they follow this very strictly. They will not intervene in the 50 to 69% criteria unless the patient is symptomatic, unless the patient is having TIAs or there is some aberration in carotid function. So 50 to 69% intervention is only reserved for symptomatic patients. In that peak systolic velocity, this is our range, and we are all very familiar with this, that peak systolic velocity is above 125 but below 230. Coming to more than 70% to near occlusion, this is a category which will invariably be intervened by the vascular surgeons, irrespective of symptoms or whatnot, because now you have a very narrow time limit before this will become near occlusion and total occlusion, and there is no way or no reasonable way to predict how long it will take from a greater than 70% stenosis to turn into a near occlusion and then total occlusion. Now remember, near occlusion is when you have a trickle of flow or you have a string sign, and I'll show you several images of that in a minute. But when you can no longer cross the lesion with a wire, you've achieved total occlusion criteria, and then surgical repair or carotid endarterectomy is the only treatment of choice, and you can no longer treat this minimally invasively like with endovascular or recanalization. So is there any questions about this criteria? Because all of you who have been on ultrasound, and all of you have, we followed this very diligently, and we are all familiar with this. So we'll talk a little bit about near occlusion and total occlusion, and we'll see why that is important. So this is a slide that's showing us that there is this trickle of flow that is going in the proximal segment of the ICA. This is the near occlusion. This is not total occlusion. This is near total occlusion. This is one step. You are right here. And you are lucky that you are able to demonstrate that there can be a thin or a floppy wire that can be negotiated to cross this lesion, and then subsequently angioplasty can be performed with stent placement to recanalize this carotid. If you are not seeing this on color Doppler, please put on power Doppler. If your techs have not given you power Doppler, they should give you power Doppler, because if there is a difference in management between near occlusion and total occlusion. And this is what it's showing you, that there is plaque, concentric plaque. I mean, has to be concentric plaque, and this is the trickle of flow going through. This is total occlusion, that even on power Doppler, here in this case, of course, it's a color Doppler image, you can't see even a trickle of flow going through, and this is no longer an endovascular lesion. You have to manage this surgically. So near total occlusion or total occlusion, very important to know, and we'll go through this in a little bit, and so that you can all understand. Now, optimal color and power Doppler imaging parameters for enhancing detection of trickle of flow in near occlusion of the ICA. So when you are suspecting that there is near occlusion, or you want to give the patient a benefit of the doubt that there can be near occlusion, what parameters do you really want to use? You want to use a transducer frequency less than 7 megahertz. You want to use a color block, steer to the center or the straight position. Remember, we talked about steer right, steer left, and how that can cause presence of color flow or absence of color flow. So you want to steer center. You want to have the box centered. The sample volume site is also steered center. There is no angulation either right or left. The focal zone is optimized, and the focal zone, as you all know, can be moved up and down, and it is optimized to the site or the adequate depth from the skin surface. The color velocity scale is reduced to 15. The power velocity scale is also reduced to 15 centimeters per second. The color Doppler gain is increased to a point of visible background noise, or to when you just start to see color flow aliasing. You want to see color. The color Doppler gain is set in such a way that you are just about to see aliasing if you go on a little higher. Power Doppler gain is increased to a point that there is visible background noise, or that there is bleeding artifact, that the color flow beyond the vessel extends up to the soft tissues, etc. The wall filter is decreased to low. The color threshold is increased to more than 80%, and the sample volume gate is again increased to 2.5 millimeters. I have discussed each of these parameters in my earlier lecture, and I assume all of you are familiar with it. If you're not, I can take this lecture again, but I have gone through all these 10 parameters, what they mean, and how they are under our control, and pretty much done the ultrasound knobology with all of you to understand how we can aid these parameters for to enhance finding just a trickle of flow as opposed to no flow. All right. One more thing to remember is if the internal carotid artery peak systolic velocity is normal, then pay attention to the end diastolic velocity. As you all know, that there is a criteria within this NACET right here that pays attention to the end diastolic velocity also. So this also is a parameter of importance, less than 40, greater than 40, and greater than 100. So what happens is as the stenotic grade increases, you go from 52% to 60% to 70%. So as the stenotic grade increases, peak systolic velocities start falling as flow through the tight stenotic segment reduces, right? Initially you see that the peak systolic velocity will increase, and that's why you have 125, 230 as your parameters to gauge your stenoses. But over time it starts to compensate because it's a stenotic segment, less blood flow goes through it. So measure the end diastolic velocity, which will invariably be raised even though the peak systolic velocity will fall. Measure the ratio of the internal carotid artery PSV versus the common carotid artery PSV. And of course, normal is 50% and the ratio is less than 2. As the stenosis increases, ratio becomes more than 4 or variable. Internalization of the external carotid artery occurs that we have seen before. And opposite side PSV increases. So as you know, if there is right-sided stenoses, that over time the peak systolic velocity of that internal carotid artery will reduce, but the opposite internal carotid artery will start showing increased blood flow as just a compensation mechanism. Well, are there any pitfalls to this absolute measurement of the artery velocity, the end diastolic velocity, and so on? Yes. A tortuous artery can, of course, because you're sampling at the site of tortuosity, there is as such inherent or innate turbulence at that site. That could be one pitfall. And of course, there's a lot of calcified plaque and you're not sure where you are sampling. That is another pitfall. And when there is marked stenosis or severe stenosis, you are not sure where to put your sample gate. That is another area which could be a pitfall. Now, the internal carotid artery assessment. So we are in the gray scale, we are looking for the amount of luminal narrowing, we're looking for the amount of plaque. Assess velocities in proper settings. We should assess the peak systolic, end diastolic, and the ratio of the PSV as I repeated. We must assess proximally in the mid-segment and distally. If no color flow is demonstrated in a tight stenotic segment, even on power Doppler, they recommend that we confirm on an alternate modality. We can just say there's no flow. Ultrasound features are consistent with occlusion, but they still say you should confirm with an alternate modality, such as a CT angiography or an MR angiography. And of course, you must assess the opposite internal carotid artery. We always do a bilateral examination to see for compensatory flow. So we are practicing this very diligently. We're doing a proximal, mid, and distal. We're trying to avoid the tortuous points. We're not trying to sample where there is marked calcified plaque. So when you come across cases like this where this is not adhered to, do point it out to your attending or to your technologist. So the IC is pretty straightforward. Now we'll come to the external carotid artery. Number one is to confirm that that vessel actually is the external carotid artery. It is not rare that we confuse the internal carotid artery with the external carotid artery. And we see that we have discussed in my previous lecture that we can do what is known as the superficial temporal artery tapping, or this as superficial temporal dance sign. Is there any reversal of flow? We want to know that. Has there been any reversal of flow to compensate for proximal internal carotid artery occlusion or for common carotid artery occlusion? If there is a common carotid artery occlusion, there will be reversal. We have seen that. Is there any internalization? Has the low resistance waveform set in an otherwise high resistance external carotid artery? Remember, the external carotid artery is like the profunda femoris. It's a muscular artery. It supplies the facial muscles. So it usually is a higher resistance. You will see diastolic reversal. You will see a dicrotic notch. All right, now we'll come to some interesting waveform patterns, which we see not too infrequently. And these are basically cardiac anomalies or central anomalies of the heart that can cause aberrant waveforms here. None of these examples are my own. I have got them from the web. Now, mid-systolic retraction is seen as what is known as the pulsus bisferiens. And this is what they're talking to. This is the internal carotid artery, and you start seeing a notched pattern at the peak of systole. It's a blunted peak, it's a broad peak, and you start seeing this notch. This is called the mid-systolic retraction and is seen in pulsus bisferiens. So what is this pulsus bisferiens? It's just a Latin term that says beat twice. It is characterized by two systolic peaks with an interposed mid-systolic retraction. Does everybody appreciate 1 and 2 systolic peaks, 1 and 2 systolic peaks? Seen in aortic regurgitation with or without concomitant aortic stenosis. It can also be seen in hypertrophic obstructive cardiomyopathy. It is occasionally seen in healthy athletic individuals or in older patients. So that is one anomaly that we have seen. So basically AR without AS, and can be seen in HOCM. Coming next to this alternating peak systolic pattern. This is the pulsus alternans, that is alternating peak systolic pattern. Let's read about it. Alternating peak systolic heights on sequential beats in a regular normal sinus rhythm. So they are alternating peak systolic heights, and this repeats itself beat after beat after beat. What are the clinical conditions that can cause this? That is intrinsic myocardial ischemia, cardiomyopathies, and any valvular heart disease. So this will occur in pairs. Large beat, short beat, diastole. Large beat, short systolic beat, diastole. So they occur in pairs, the first one being larger, the second one being shorter, and then the normal antegrade flow in diastole. Coming third to severe aortic regurgitation, you again see two systolic peaks, but you see a diastolic reversal. So that is different from our first pattern that we saw, which was pulsus bisferiens, in which you do see two systolic peaks, but there is no reversal in diastole. As opposed to this one, look at the difference. There is again a mid-systolic retraction here. You have a first systole and a second systole, but you alongside also have a retraction, or you have a diastolic reversal. So two systolic peaks associated with a diastolic reversal, and that is seen in severe aortic regurgitation. So this is again, one systolic peak, two systolic peak, but diastolic reversal. Now we come to the fourth type, which is the water hammer pulse. This is also seen in aortic regurgitation and is reversed early diastolic flow in both common carotid arteries with elevation of the peak systolic velocity and a sharp systolic upstroke. While this also is seen in aortic regurgitation, this is yet another waveform. Now we've seen three waveforms so far which can occur in two waveforms in aortic regurgitation, one waveform in aortic regurgitation without aortic stenosis. So this is yet another type of a pattern. Let's come and look at this one. If Louise will remember, Louise, this is very akin to that vertebral artery pattern, which is that bunny on the side, right? Or the bunny is sleeping on the side, because we had done a project on that. Now, hypertrophic cardiomyopathy, this is called the spike and dome pattern, and they say it is very characteristic of this hypertrophic cardiomyopathy, the spike and dome pattern. And it looks like a bunny sleeping on its side with a bunny ear and then the body of the bunny and the tail of the bunny. The bunny ear, the body of the bunny, and then the tail of the bunny. And this is usually seen in ventricular outflow obstruction in patients who have hypertrophic cardiomyopathy. Appearance is always bilateral. Remember, if you're going to be attributing something as a cardiac cause, then that should reflect in both carotid arterial systems. Just seeing it in one, then you have come more distally, then it could mean more innominate artery stenosis, or it could mean more subclavian artery stenosis. I put together this section on carotid dissection after I spoke with Tom Alexander. We had a case of carotid dissection during his rotation, and I really didn't know much about it. So when does this carotid artery dissection occur? It occurs in trauma, when there is seatbelt injury or repetitive trauma, like a whiplash injury, back and forth injury of the cervical spine. Occasionally, spontaneous and isolated to the carotid arteries can occur in vasculitis, such as Marfan syndrome, Ehlers-Danlos syndrome, fibromuscular dysplasia, hypertension, or drug abuse. It can also occur as a direct extension of aortic dissection. We've seen that on many of our carotid angiographies. Rare, but dissection of the ICA is most common cause of stroke in young patients. You do remember that it's a very rare cause, but in young teenage patients, this is one of the most common causes of stroke. Most ICA dissections occur at the level of the carotid bifurcation. So you will see that the proximal internal carotid artery is invariably involved when the dissection occurs. So what do you see? This has been described as a bizarre waveform, that there is no set waveform in carotid dissection. Usually you have a low peak systolic velocity with a highly irregular waveform contour with many spikes or fluttering with reversed or bidirectional flow, but there is nothing standard. It's just a bizarre waveform. It's not always that it's bidirectional. It's not always that there's fluttering or there are multiple spikes in systole, or such that it may be difficult to distinguish from systole to diastole. So I have seen that in that particular case of mine, I don't know if Tom remembers, but it was a very bizarre bidirectional waveform, and it was unilateral, and we could not, initially I thought it could be aortic regurgitation because it was bidirectional, it was occurring below the baseline, but it was only unilateral. It was not occurring in the opposite side, and then it proved to be on a different study as a carotid dissection. An intramural hematoma causing a long segment tapering of the ICA without a break in the intima can also be well associated with this dissection. The residual lumen may be narrowed markedly, creating a string sign or a pseudo-string sign, which is luminal stenosis, but due to the intramural hematoma. Thrombosis of the false lumen can also mimic a stenosis. The waveform may be indistinguishable from a stenosis, except that it typically extends over a much longer segment and there is no plaque visualized. So do remember, this carotid artery dissection is more common in younger individuals. Okay, in younger individuals, people who are more prone to trauma, like seat belt injury, etc. Vasculitis, also these are congenital diseases. They usually set out right from their adolescence. So these can occur more in younger population. So there is no plaque or hardly any plaque, yet there is a long segment stenosis. Whenever you visualize something like this, consider aortic carotid dissection as one of your differentials. The presence of early diastolic flow reversal in the ipsilateral common carotid artery, reduced peak systolic velocity and diastolic velocities in the ipsilateral internal carotid arteries. These are all non-specific but warrant a search for a cause of increased peripheral vascular resistance. So that's what I wanted to bring your attention to, that this is a unilateral, bizarre waveform, and no amount of plaque can explain it. It's just an unexplainable phenomenon like it was with that patient. There's no plaque, it's a younger patient, and a very bizarre, non-specific waveform. So they've given one example here about this particular patient. I want you to look at the waveform. There is no waveform that we spoke about. I mean, this could be a systolic peak, but the diastolic reversal is occurring earlier than systole. So this is a very bizarre appearing waveform that the diastolic reversal appears first, then systole occurs, then there's nothing. Then diastolic reversal occurs first, then systole occurs. So it's a very bizarre waveform that happens in this patient with carotid artery stenosis. So want you to remember as one of the things. This was another patient here where, I don't know whether you can see it well, but we do see partly an echogenic flap here and an echogenic flap here in this patient with the internal carotid artery dissection, and subsequently there was a hematoma, there was no vascularity, and this was known to be a hematoma. Okay, the last artery that I'm going to discuss in the carotid arterial system is the vertebral artery. We've talked about this before with Louise. He presented that at the research symposium, but we'll look at a couple of cases now. So we always want to look at and identify, is it a normal or a hypoplastic vertebral artery, or is it not seen? Sometimes that aberration in caliber of the right and the left vertebral artery is not available to us on color Doppler. It's just not available to us because of the artifact of overbleeding. You don't see any vascularity, so the technologist turns up the color gain. When she turns up the color gain, there is the bleeding artifact. You want to see the waveform pattern, definitely you want it to be a low resistance waveform. You want to see direction of flow because we talk about the subclavian steal phenomenon, and you want to see the peak systolic velocities. And as I have mentioned to all of you, that the variation in peak systolic velocities bilaterally should not be more than 15 centimeters per second. It should be within the 15 centimeters per second range between the right and the left. So what are the few aberrant waveforms that we can see in the subclavian, in the vertebral artery? Number one is a reversal of flow. That is stenosis or occlusion at the subclavian or the innominate artery level. We'll see examples of that. We'll see transient systolic reversal. It is seen in a lesser degree of stenosis of the subclavian. We can see high resistance waveform pattern, which like any other arterial system, when a low resistance artery becomes a high resistance artery, means you're approaching a stenosis. So a distal stenosis, you are only, just remember that the NACID criteria as also the certifications of IACVL only ask us to sample the vertebral artery at one location, the proximal vertebral artery. We are not obligated to do a proximal, mid, and a distal vertebral artery interrogation anyway. So if you're looking at the proximal vertebral artery and you see a high resistance waveform, you automatically know that downstream, somewhere in the vertebro-basilar system, there is an occlusion or a stenosis. And a low resistance waveform, if a vertebral artery becomes more low resistance than it already is, you know it's a proximal stenosis, and this is a tardus parvus waveform. So these principles are very, very universal, and they apply from head to toe in any arterial system, and all of you are very well versed with that. So just one example, that this is a distal vertebral artery stenosis, because this vertebral artery, number one, it's become like a tabletop. It's very, very spectral broadened, and there is no antegrade flow in diastole. So you know this is becoming a high resistance waveform. Now, pulsus tardus waveform. Tardus parvus waveform, as we know, can occur in a post-stenotic segment, which is late and slow, and we have all seen that, late and low. And stenosis at the vertebral artery origin, we've all seen that before too. Now, remember that you have seen with me that many a times a tech is not able to show us a unilateral vertebral artery, and that happens once in every 15-20 carotid ultrasounds. So what does that mean if you're not seeing it? Well, it could be occluded, number one. It could be congenitally absent. It could also be dissected. Who knows? Who knows what's going on when you don't see something? So when you don't see a vertebral artery on Doppler, don't stop there. Don't just say it's either absent, atretic, or congenitally diminutive, or whatever. You must work that up with the second modality. I always order a CT angiography just to be sure. What if there is a vertebral artery dissection? What if there's a thrombosis? What if there's a stenosis? All these three will be seen in the umbrella of non-visualization sonographically. So you want to go with the worst possible prognostic feature and have a CT angiography done if there is non-visualization of the vertebral artery. Now coming to the subclavian steal phenomenon, all of you know that, and we'll go through that again. So subclavian steal is a stenotic occlusive or a steno-occlusive disease proximal to the origin of the vertebral artery. So there is stenosis of the subclavian proximal to the takeoff of the vertebral artery, resulting in decreased blood pressure in the arm distal to the steno-occlusive disease, causes ipsilateral vertebral artery flow alteration, severe stenosis, flow reversal occurs in the ipsilateral vertebral artery as compensatory collateral to the vascular territory beyond the subclavian stenotic lesion. Does that all make sense? Let's look at that with an image. So it's trying to tell us that whenever there is a stenosis of the subclavian artery, like here, so this is of course the ascending, the aortic arch. Here we see this is the innominate trunk, the carotid and the left subclavian artery. Whenever there is a stenosis which is proximal to the takeoff of the vertebral artery, this vertebral artery becomes a collateral and is obligated to serve the arm. Does that make sense? It becomes as a collateral channel to serve the limb, to perfuse the limb at the cost of the posterior circulation of the brain. So this is what is the subclavian artery. Now on the right side where you have the innominate trunk, the same principles apply. Only thing is that the stenosis is happening proximal, that is at the innominate level. When it happens at the innominate level, you still have the subclavian artery and the carotid artery coming off, but you have subclavian artery stenosis because the innominate artery comes off, subclavian artery comes off the innominate artery, and therefore the vertebral artery serves as a collateral to supply that subclavian artery distal to the takeoff of the vertebral artery. Now there is a classification system of the subclavian stele. We don't really use it, but I wanted to be thorough and I wanted to present everything there is to know. So number one, there is reduced antegrade flow, that is stage 1. Stage 2 is reversal of flow during reactive hyperemia, testing of the arm. Remember, does anybody know how we can test for subclavian stele? What maneuvers do we do in testing for subclavian stele phenomenon? Okay, we'll come to that in a second. And then the third stage is that there's permanent retrograde vertebral artery flow. So in stage 2, it happens intermittently. What do we do, Tom? So you have to work up that arm. That's number one. You want to work up that extremity where you feel there's ischemia. So you want to cause some ischemia because the vertebral artery flow cannot compensate for, it can compensate for a limb at rest. It can't compensate for a limb in action or in activity. So you want to find out in this stage 2 by doing this maneuver, is this intermittent reversal of flow in the vertebral artery, or is it stage 3? Is it permanent reversal of flow in the vertebral artery? So these are just the few waveforms that I found online. I don't think they're just telling us stages. I don't think it's very important for us. So I just wanted to see that the provocative maneuver is either giving a patient a dumbbell or having the patient do rapid extension and flexions or having the patient do rapid overhead movements of the arm. Anything that will over-exercise that particular upper extremity. So they see that at rest, there is some diastolic reversal, but majority of the flow is above the baseline. But after you have exerted that arm, or you have put an blood pressure cuff on that arm with rapid deflation, that causes reversal. So this is stage 2, where at rest you have antegrade flow in the vertebral artery, but after exercise or after rapid deflation of a blood pressure cuff, you are having reversal of flow. Again, this is another patient that at rest, the vertebral artery flow looks pretty normal. There's a good peak systolic velocity, there's a good upstroke, there's good antegrade flow in diastole. The pattern never touches the baseline, but after inflation of a blood pressure cuff with rapid deflation, you are able to make it from stage 1 to stage 2 because there is intermittent diastolic reversal. Does that make sense? Okay. So what does this blood pressure cuff maneuver do? Let's read about it. The blood pressure cuff maneuver induces reactive hyperemia in the distal arm and increases blood flow across the subclavian stenosis, resulting in a complementary pressure drop and change in direction of blood flow in the ipsilateral vertebral artery towards the lower pressure subclavian origin. Does that make sense? So just kind of making a sump effect or making a low pressure area so that there is more perfusion to that limb. This is that rapid inflation with rapid deflation of the cuff. Thank you. Are there any questions?